So much. My name is Roelof Ettema. I'm from the University of Applied Science, Utrecht in the Netherlands. And I'm on behalf of Ferdy Pluk, my colleague. He's too busy, he was too busy. He took too many tasks at this conference, so I said to him, well, I take over this chairpersonship. So that's what I do now. And welcome to the session, Empowering Patients and Caregivers to Self-Care and Self-Management. Self-Manage. This is a very important subject. And we have some very enthusiastic presenters today. And what we shall do is first we do the presentations, and afterwards we have a general discussion. Is that okay by you? Is that also okay by you? Yes? Okay, we have also some people at home. It's very important. We have the remote attendance. So also welcome online. And what is very important is if we talk through a microphone. So if you give a reaction from the audience, please search for a microphone so the people, here there is a microphone on the side and there is a microphone on the side. You can use that, but it's at the end. Use that because people at home or people not here online can hear you. Okay, let's give space to Lena de Thurah, and you are talking about digital self-monitoring tools in mental health care, isn't it? Yeah. Okay, floor is yours.
Thank you. Thank you very much. Nice to see all of you here today. So yes, I'm Lena de Thurah. I'm a PhD student at the Center for Contextual Psychiatry at the University of Leuven in Belgium. And today I would like to talk to you about how we can understand the appropriation of digital self-monitoring tools in mental health care. So as you all know, digital technology is becoming more and more common in our healthcare systems today, as they are used to manage and collect and share health data. And at the Center for Contextual Psychiatry, we're particularly interested in using and how we can use digital self-monitoring tools such as smartphone apps and wearables, smartwatches, Fitbits, to allow people to collect data about themselves that can be used to support more person-centered care. Unfortunately, we see that a lot of these tools are struggling to reach integration into our healthcare systems, and that they are often abandoned by users. So therefore, we are interested in getting a better understanding of what makes people adopt, adapt, and integrate these tools into their daily practice. For this, we conducted what we call the Improve pilot study. This is a study in which we tested a digital self-monitoring tool based on the experience sampling method. This is a method that you can say it's a structured diary technique that allows us to collect information about people's mental health, their well-being, their psychiatric symptoms, but also information about their daily life contexts, their activities, and whereabouts. So we recruited clinicians and clients from a psychiatric unit to test this tool in a three-step intervention. In the first step of this intervention, we asked clients and clinicians to sit together in a startup session to discuss how to use this tool as a part of their therapy. So the tool allowed for different personalization options. So for example, they could discuss whether there are specific symptoms that the client were interested in monitoring or specific problems that they should attend to. In the second step of the intervention, the client would then self-monitor for a week. The client would receive 10 notifications every day, prompting them to fill out these short self-assessments about how they were feeling, whether they were experiencing symptoms, and what they were doing and who they were with. In the final step of the intervention, we asked people then to sit together or clients and clinicians to sit together again and look at the client's data. They could, for example, as you see here, look at how the client's mood fluctuated throughout the week, which were the bad moments, which were the good moments, and what had happened in these moments. After completing the intervention, we then interviewed 7 clinicians and 11 clients to learn about their experiences with using the tool. Inspired by the model of technology appropriation, we wanted to examine first what were people's prior experiences and expectations to using this tool, because those are very important in when people make the initial decision to adopt a tool. We then wanted to look at what actually happened when people started using the tool. So in practice, what were people doing with the tool? This is the phase where people get familiarized with a new technology, where they explore its capabilities, but also a phase where they might decide to do something different with the tool than what we had expected. So maybe using it in different ways than what was initially intended. Finally, we were interested in examining whether they would be interested in integrating the tool into their daily life practice and use it in the future. So looking first at prior knowledge and expectations, we found that clinicians actually already had a lot of experience with analog self-monitoring tools as a part of their therapy. So a lot of them had already used different diary techniques or different questionnaires that clients would fill out on a regular basis. We also found that some clinicians already had experience with other digital tools, that could be VR or online consultations or different online platforms that they would use with their clients. Most clinicians expected that it would be easier and better to use digital self-monitoring tools than analog tools, and that they would also make more things possible, as this digital data could be used in a different way than when collecting analog data. Most clinicians also had the belief that having digital tools available as a part of healthcare was very important, and that it was important for them as healthcare providers to learn about these tools and be able to master them. And some clinicians also voiced a concern about the fact that digital literacy could become a burden or a barrier, both among clients and clinicians to implement these tools. Looking at clients, some of them also had experience with analog self-monitoring, so diarying to keep track of their mental health. And some also had experience with different digital mental health apps, for example, for breathing techniques or cognitive behavioral therapy. Most clients were driven by a curiosity to see what these type of self-monitoring tools could do for them, and hope that these tools would give them more insight into their mental health. So what happened when people then started using these tools? Well, what we got as feedback was that clinicians find that it was highly time-consuming for them to learn to use these new tools and to integrate them into their practice. They generally found that the system complexity was too high compared to their technological competencies, and that especially the advanced features, for example, personalizing the client's questionnaires, required extra effort and time that they felt they didn't have. Many clinicians also experienced that it was somewhat difficult for them to interpret and navigate the graphs about the client's data, but what we saw was that some turned to co-interpretation with the clients to make sense of the client's data, and that this was really helpful for them in actually using this data and getting valuable output. So on the client side, many clients reported that complying with the assessments was quite difficult for them. They were simply too busy in their everyday life and didn't always have time to respond to these notifications. Many also found that the assessment burden or the assessment frequency was too high. And some also found it difficult, this whole exercise of actually labeling and scoring their emotions was not easy for them. Some also found that they really needed clinicians' help to interpret and make sense of their data, and that they felt that this wasn't something that they would be able to do themselves. But what were the effects and the added value then of using this tool? Well, many clients experienced that the self-assessment actually trained their emotional self-awareness, that having to reflect on how am I feeling right now and what am I feeling right now really made them much more aware of their emotions. Also, the tool allowed the clients and clinicians to have a different type of dialogue about the client's mental health problems, because they could sit together and discuss the client's data. And together, these two things gave new insights to both clients and clinicians about their mental health. And this insight and awareness also helped identify action points, so what could be done differently in the client's therapy and in the client's daily life. Clinicians also experienced that the tool actually helped correct clients' negative beliefs about themselves. The clients saw that they were not always feeling bad, but actually also sometimes feeling really good. Again, these things then led clients to report that they actually felt that they were better at dealing with things in their daily life, especially stressful situations, but also managing their emotions, because they were now aware of which situations could be stressful for them and how their emotions could be influenced. It also motivated some to make changes in their daily life, for example, focusing on getting better sleep patterns, getting a better rhythm, exercising more in their everyday life. And that this overall made them feel better and more confident. So are people then interested in using this tool in the future? Well, what we saw was that the clinicians who reported that they would be likely to use this again were also the ones who experienced the most benefits, whereas the ones who were more hesitant and wasn't sure were the ones who were struggling the most to use the tool and requested more in-person support on how to use this tool and integrate it into their practice. On the client side, again, experiencing an added value of the tool were linked to wanting to use the tool again, but most clients, again, were a little hesitant and said maybe they would be interested, but the assessment scheme definitely needed to be changed and the assessment burden needed to be lowered. The ones who were not interested in using the tool again were also the ones that experienced negative reactivity to the self-assessment, so they would feel stressed about having to fill in the assessment, but they would also experience that the assessment would actually sometimes enforce negative emotions that they were experiencing. So in conclusion, what we learned is that when we're looking at experience and expectations, clients and clinicians had limited experience with using digital health tools in practice and no experience with using self-monitoring tools or digital self-monitoring tools. But clinicians really believed that having these tools available was very important and useful. Looking at actual use, we found that the tool did have added value for some people, but the effort to integrate these tools into the daily practice remains high for a lot of our participants. And this was mainly due to a mismatch between system usability and user competencies, the high self-assessment burden that clients experienced, and difficulties in interpreting clients' data. However, we did see that co-interpretation was very helpful in solving this problem and making sense of clients' data. And regarding future use, not surprisingly, we see that whether people are interested in using these tools is highly dependent on the balance between experienced benefits and the effort required to achieve this. So in closing, I would just like to say thank you for your time and acknowledge my co-authors, my collaborators, the funding body that made this research possible. If you have questions or are interested in learning more, you can always contact me. And this work is also available as a preprint on the Open Science Framework.
Thank you, Lena. Thank you so much. Again, I would appreciate if the audience can keep their questions and we go to the next presenter, and that's Isabel Caven. Isabel, you're going to talk about empowering and supporting young caregivers interacting with the healthcare system, isn't it?
Yes.
Yes, the floor is yours.
Thank you so much. Okay, cool. Hi, everyone. I'm Isabel, and I'll be talking today about supporting and empowering young caregivers in Canada and their healthcare interactions. I'll be sharing findings from an ongoing project that I'll emphasize throughout that it's ongoing and there'll still be lots of learning as we move forward. So to start, our project team, you can see our project team on the left there, and the asterisk is to remind me that Karen, her previous research was funded by an Ontario Ministry of Health Early Researcher Award. We also have an advisory group of young caregivers, as well as international advisors who are experts in this space. And the big logos on the right there are our caregiving and organizational partners who are incredibly important to this project. So to start, as for who young caregivers are, our working definition of this project is people under the age of 25 who provide significant ongoing care support to a family member or loved one. The photo on the right is myself and my eldest sibling, who gave his permission for me to share this photo. And he has an intellectual disability, and I have grown up supporting him. I will be holding on to other definitions of young caregivers, which are people under the age of 30 as I move forward. But I'm part of over 1 million Canadians who provide significant care support. And I feel very grateful to be able to bring my lived experience into this space, but I always want to recognize that I come from a place of a lot of privilege and have had the resources, networks, and supports to provide caregiving support without a lot of the negative consequences that a lot of other young caregivers can experience in their caregiving journeys, such as impacts on their overall health, well-being, and development at a really pivotal time in their life. And so as for healthcare, we know that young caregivers have really significant healthcare responsibilities, whether that be from sitting at bedside, talking to a physician, or being in the home administering and tracking medication. So as for challenges, Marianne Saragosa led a really great project to understand the kind of key touch points that young caregivers have as they interact with the healthcare system. And a lot of these challenges can be summarized into the fact that young caregivers are under-recognized, under-acknowledged, and aren't communicated with enough. So to address that, our project has 2 main objectives. So first, using a survey, we are learning from healthcare providers across the country about really, do they know what a young caregiver is? Can they kind of recognize the tasks that they take on, and are they able to support them? And then using what we've learned from the survey, as well as our team's previous research, is actually translating these findings into some sort of actionable co-designed resource for healthcare providers to actually support young caregivers within their clinical practice. So how we're doing this, I mentioned an online survey. This was adapted from a group of researchers in Switzerland and specifically looks at awareness, recognition, understanding of challenges and tasks, and ability to support and refer to kind of organizations. Recruitment is happening in a lot of different ways. The survey is still recruiting using listservs, professional organizations, community organizations, and social media. And if you do any research recruitment over social media and have experience kind of fraudulent or bot responses, please talk to me afterwards, but we're using a really great paper that kind of helps screen some of those responses so we know that they're all real people. And as for co-design, we're working with kind of a modified experience-based co-design process, which is a participatory healthcare quality improvement tool in a series of 3 co-design workshops. So as for our findings, as I'll emphasize again, these are our findings as of March, and the survey is still open, so this will change. But right now we've heard from a really high amount of nurses, as well as physicians and OTs, occupational therapists. And our study is cross-country in Canada, but you can see here we've heard from a lot of healthcare providers in Ontario and are actively sort of working to reach healthcare providers across the other provinces and territories. And as for type of clinical practice, you can see on the slide on the left here of kind of where we're seeing healthcare providers coming from, as well as kind of what type of setting they practice in, inpatient, outpatient, or kind of mixed practice. And so one of the questions on the survey was just to ask healthcare providers if they are encountering or aware that they're encountering young caregivers. So over 60% of our samples said yes, that they see them in their practice. This is a little higher than some of the international literature, but there's also quite a few people who aren't aware that they're encountering them or haven't kind of thought about this topic. And here's a quote on the slide from an OT about kind of who they see in their practice in terms of young caregivers. And then when we look at the same question about encounters by clinical role, we can see the kind of breakdown between allied health, nursing professionals, and physicians, and seeing that nursing staff are potentially aware of those encounters a little bit higher than other types of clinicians. And similarly, looking at practice setting, you can see there's kind of an even spread across different types of practice. And so one of our first question was about encounters, and our second question is about support. So are people actually able to support young caregivers? And this goes down a little bit from awareness, and we see that just over half of our samples said yes, they could support young caregivers. And this quote on the slide there by another occupational therapist, I think importantly points out that the main support from acute care is giving the patient appropriate referrals to public respite and home care supports. So to move into the co-design phase, as I've talked about, this is a process of 3 workshops. The first 2 workshops we have done and I'll touch on, but really the goal is to kind of come together with young caregivers, healthcare providers, and community organizations to try and figure out resources and interventions to support healthcare providers in their encounters with young caregivers. And our last co-design 3, which will be coming up in June, is kind of refining this idea and what this resource looks like. So at our first co-design session, you can see the types of attendees we had there. And our focus on this session was feeding back and sharing back what we heard through the survey with attendees and trying to figure out if this aligned with their lived and clinical experiences, and together prioritizing what some of these key challenges in these interactions to focus on. In our second workshop, we thankfully had a few more clinicians in the room, but we kind of continued to build off these prioritization activities and started to really brainstorm how we were going to address these challenges. And as I'll touch on throughout this work, I think important in co-design 2 was the fact that we were informed by current resources that exist and are offered by caregiving organizations across the country, and really tried to kind of build on what's out there or talk about how certain things could be modified to meet needs or identify some of the gaps in some of the resources. And so when we come back to the survey a little bit, another question that was asked was about what types of resources healthcare providers wanted in order to support them. And very unsurprisingly, not many people wanted plus 1-day training sessions, but there was a lot of appetite for brochures, websites, and modules. And when we kind of juxtapose this with the resources that are offered by our caregiving organizations, which some of these may not be tailored to young caregivers, this kind of shows that there are resources out there. It's just a matter of kind of making sure they're tailored to young caregivers, and also we get them in the hands of those who need them, whether that be young caregivers or healthcare providers. And so some of our key learnings to date, which I'll talk through from our first 2 co-design sessions. The first thing is this young caregiver label. You may not have heard of a young carer before this, and there's a lot of conversation about this label and whether it can be helpful or perhaps for some people doesn't align with their individual preferences, or potentially within kind of the family unit is stigmatizing. But we had a lot of really great conversations about the utility of this label, and hearing time and time again from young caregivers that this label is something that actually affirms this part of their identity and shows to them that they're doing more than just kind of helping. They're actually a caregiver. And from the provider side, having this label is a really important piece of recognition, because we need to recognize and see young caregivers before we can support healthcare providers in supporting them. The other piece that we talked about a lot was this idea of kind of system navigation and who that burden rests on, and kind of co-producing resources for young caregivers adds an additional layer that they have to actually find these resources, advocate for use of these resources, and that kind of burden falls them back on them. And so figuring out how we can kind of champion with healthcare providers in the room to incorporate resources in their practice so they can support young caregivers themselves and be the one to kind of be that touch point for those resources. And the last kind of key learning is just understanding that every caregiver and every young caregiver is different, and they have a different story, and making sure that we are providing and tailoring resources that encompass the entire family unit and offer kind of support instead of stigma, are mindful of cultural diversity and the cultural nuance that plays into caregiving, and then also in Canada, making sure that these resources are able to support young carers, whether they live in an urban center or a small town. So as for our sort of next steps with co-design, this is kind of where we've landed and we'll work on at co-design 3. It could change a little bit, but we're focusing on 2 key things. So the first of them is providing integrated intake forms for healthcare providers to actually assess and recognize young caregivers, whether that be sort of admission to hospital or kind of first clinical encounter. We'll figure out what that looks like. And this intake form would be embedded in a toolkit for healthcare providers in order to support them in learning to recognize and refer young caregivers to different community resources and caregiving organizations. And the one thing to note is that I think having healthcare providers in the room helps to kind of take the toolkits that are out there and the resources that are available and ask them to kind of comment, you know, how will you actually use this in your practice? How can we make this something that's accessible to you and you can use efficiently and quickly and kind of provide someone with a resource? And then the last part of this that I think is really cool is that there was a lot of talk about how we can improve recognition of young caregivers. And especially caregivers in our healthcare systems at large aren't recognized, but young caregivers are also something people may not have ever heard of. And we will have a design student come with us in the summer to kind of focus on the storytelling piece to help kind of spread awareness amongst healthcare providers of what a young caregiver is and the challenges they may experience as they navigate healthcare. And kind of embedded in these stories are actual resources that people can kind of learn about young caregivers and in the same breath find resources to help support them in their clinical practice. So I'll do limitations first. I think one of the limitations of this work is hearing from healthcare providers who are already kind of engaged and know what a young carer is. We also need to work to hear from healthcare providers who have no idea what a young caregiver is, and we're still kind of working on our recruitment as we go along. Healthcare provider recruitment is a challenge. They are a busy bunch, but we have really passionate healthcare providers who have given their time as well, and then continue to kind of increase our survey numbers across the country to hear from people outside of Ontario. But to end on a positive, some of the strengths of this work is that we aren't kind of starting from zero. The challenges that we're hearing about in terms of young caregivers' clinical interactions are informed by our team's previous research as well as this survey. We also have a knowledge user advisory embedded throughout this work. Our community caregiving organizations have given a lot of time to this project from the very start. And we also have a very passionate and very motivated advisory group of young caregivers who are also sharing kind of their feedback and their thoughts on this process. And then the last strength is that we're just not trying to reinvent the wheel. We're kind of working with what's out there, hearing from people who we need to hear from in order to make sure that we can kind of modify, improve, and get resources into the hands of people that need them. And these are my references. Thank you for your time.
Thank you, Isabel. Thank you so much. Now we are on for Nicola. Yeah, Nicola, you're going to talk about a national framework for social prescribing. The floor is yours.
Thank you. Diolch. Prynawn da, good afternoon. My name is Nicola Evans. I am Head of Health Inequalities and Healthy Communities within Welsh Government, and first of all I'd just like to thank you all for sticking with us. I know it's been a really long day for everybody and there's so much information that's come through on such a fabulous day, so thank you very much for sticking with us and coming along to the session. So in my session today I'm just going to set out how social prescribing has developed in Wales and how the framework came about. Explain what we mean by social prescribing, because we've got a slightly different definition to social prescribing than the WHO definition. To map out the core objectives of the national framework and some of its themes, and then just to sort of highlight some of the tools and guidance we have and what we plan to do in the future, and then just some personal reflections. And if I've got time, I've got a little video. So just to give you a bit of a timeline in terms of how social prescribing has developed. So for those of you who aren't aware, social prescribing really came out of a movement which was recognising that a lot of people that turned up in GPs weren't there for medical needs. They were there because of social and economic issues, and they didn't know where else to come from. And the movement really started in the UK and in England, and it quickly took hold in Wales, and a lot of pilot projects were set up, really a grassroots movement that came from the communities and from projects that were developed locally. And it, as always, it took a little bit of time for the government to sort of catch up with what was going on at the local level. And within Wales, we really started to take interest in social prescribing in 2016 as a government, and we made a commitment to run a couple of mental health social prescribing pilots within our programme for government. And there was a number of events that happened. There was a Senate debate on social prescribing, some mapping of what was happening, and lots of policy interest across Welsh Government, across the whole organisation, about what social prescribing was and what it could deliver. And that really sort of crystallised itself within Connected Communities, our strategy for loneliness and isolation. And that, for the first time, set out a couple of national actions that we could do in order to really embed and develop social prescribing across Wales. And that was published towards the end of 2019, and then in 2020, we all know what happened. All governments across Wales, all public health teams across the world were diverted from a lot of national activity due to COVID, and a lot of work was diverted into dealing with the immediate crisis. But on the ground, it didn't. On the ground, they really stepped up. They really took on board what it was that they could deliver. And a lot of the organisations offering social prescribing in Wales really proved their worth and their mettle about how they can really work with the community to offer support for people on an individual basis. And you know, once we'd all sort of calmed down from dealing with the immediate impact of the pandemic, again, interest really sort of peaked within Welsh Government about what social prescribing could offer. And when the Labour government was elected in 2021, it was a programme for government commitment was made about developing a national framework for social prescribing. But what was it? What did that mean? I mean, that was just a line in a manifesto commitment that we would develop this framework. And so as policy officials within Welsh Government, we spent a long time trying to work out you know, what it meant across Wales, what was the baseline, what was happening in Wales, talking to stakeholders. And it was really led by Lynn Neagle, who was the Deputy Minister for Mental Health and Wellbeing, who had a really strong interest in this. And she was really, really clear with us that what she didn't want to do was dictate to local projects how social prescribing should be delivered. But what she wanted from the framework, and when we talked to people, what they really wanted from the framework was something that helped social prescribing grow and helped to do the evaluation and build the evidence base for it. So, as I said, there was a long period of engagement. We worked really closely with partners such as the Wales School for Social Prescribing Research, Public Health Wales, with practitioners, with our third sector voluntary organisation, with primary care clusters, to really get a sense for what social prescribing meant to people in Wales. And then we pulled all that together into what we thought the model might look like, and then launched a consultation exercise where we drilled down into a lot more detail. So that again led to, you know, we had some really rich and diverse responses back. We did some testing with sort of priority groups to sort of see what our language was. And then finally, after what seemed an awful lot of work and an awful lot of time, we finally published the framework just before Christmas last year. So, and I'm going to talk to you a bit more now about what that framework contains. So what did we find out from the policy engagement work that we did? So, you know, there's the first thing we found out, that there's been this period of growth and it's really shot up, and there's been many more referrals into social prescribing. There's lots more organisations now offering social prescribing over the last decade. But there's been a lack of standardisation and consistency, both in the terminology used to describe it and in the model adopted. And many people, when they talked about social prescribing, they were talking across purposes. So some people were talking about the referral into it. Some people were talking about the what matters conversation. Some people were talking about the activities themselves. So there was lots of confusion. So that meant that people both within the public and in the workforce didn't really know what we were talking about. And, you know, when you're trying to explain complex terms and new models of care for people, then people knowing what you're talking about is really important. There was also a lack of leadership and ownership to drive improvements. There was no sort of central body that sort of could see it and was holding people to account. And what came across was really important was that while we, as I said, it was important to have these national standards and guidance, people didn't want us to say it must be delivered in this way and it must be delivered in specific ways, because obviously models of care need to be adapted to meet the needs of local services. So, what is social prescribing? So, in the WHO, the definition of social prescribing is very much rooted within a healthcare model where somebody is referred from a healthcare professional into a community asset or into a community. But in Wales, we have taken that and boiled it down to what we believe the function of social prescribing is, and think of it as an umbrella term that describes a person-centered approach to connecting people to the local communities. So that doesn't matter what setting it's in. So it doesn't matter if it's in a healthcare setting, it doesn't matter if it's in a third sector setting, it doesn't matter if it's in a university setting. So social prescribing in Wales is that function of connecting somebody to a local community asset. And by community asset, we mean community groups, interventions and services which could be delivered online or in person, as well as physical activities and physical assets. And then the social prescribing pathway, we've sort of set that out as containing these sort of three key elements. So the referral into an organisation offering social prescribing could come from a number of different routes. So it could be a self-referral, it could be a healthcare referral, it could be through the third sector, community and voluntary sector organisations, or it could come through statutory services. So the referral route into social prescribing isn't limited to one organisation. It could come from a number of different things. We've also included targeted referrals, because we do have examples in Wales where we've offered, through using population health management, we've offered individuals targeted interventions. So we've included that as a referral route into social prescribing. So then social prescribing is where the what matters conversation happens. It's where action planning is done, and it's where signposting and onward referral is undertaken, and you work with people to develop that action plan, and where people monitor and record the outcomes of that activity. And then finally into community assets. And by community assets, what we mean by that is people are referred into what matters to them. So it's not a particular service or activity. It depends on that person. It depends on what matters to that person. But we've sort of classified them into the following. They tend to be either sort of creative referrals, so music, dance, anything creative to help people's general well-being, exercise referrals, green-blue referrals. We talk about into nature, into water-based activities, into education on referral, and increasingly welfare support referral. So this is for people who have, need to sort of, they might have issues with debt or financial support or housing concerns. So it's that referral into those organisations that can offer in that support. And because our definition is so broad and the models that we're offering is quite wide, what we set out then to do through the national framework is to deliver on a number of core objectives across Wales. And those were about developing a shared understanding of what we meant by social prescribing, to set out some guidance and tools for people to support the workforce and drive up skills, to ensure a quality of provision, to monitor and evaluate, and ultimately to improve outcomes. So everything that we will be delivering under the remit of the framework will have those 5 objectives that we're looking to deliver. And across each of those, we will also have a number of cross-cutting themes. And that includes addressing inequality and inequity, because there's a real risk with social prescribing that it just goes to the people that don't particularly need it, and it's seen as a bit of a something for the worried well rather than for the people that might need it most. So we need to really keep that at the forefront of our mind when we're developing guidance for it. That it's across the life course, so primarily in Wales, social prescribing is targeted at adults, but there is a growing incidence of social prescribing for children, and that's something we need to bear in mind. But when we are developing guidance for social prescribing, we need to take that into account when we're developing them. Within Wales, we have a requirement to do everything bilingually, and not just translate documents into Welsh, but think about how our policies can promote Welsh, and we can actively engage with Welsh language communities and promote the use of Welsh language so that we have that active offer. And the final cross-cutting theme is that it's relationship focused, and this is something that the Deputy Minister was very, very strong on, in that it has to remain person-centred, it has to keep the individual at the centre of what we're looking to achieve. So we've got a number of guidance out there for people that they can start using now. So as part of the launch, we developed an explainer video, which hopefully I'll share with you now so that you can explains much more eloquently than I can what social prescribing is and how we framed it. Then we've got a range of lovely case studies that show social prescribing in practice and how it's being implemented on the ground. The Wales School for Social Prescribing Research has developed a glossary of terms which really does help demystify what social prescribing is and takes you and recognises that there are differences used in different sectors, but then ultimately it's this, what they talk about is the same thing. So as an example, we talk about a social prescribing practitioner, but in the third sector they call it a community connector. In primary care they call it a link worker. In some healthcare services they call it a wellbeing coordinator. So within that they have this umbrella term, and then it sort of goes into detail about what it might be known in different sectors. And then the final thing that's available is we have a competence framework which is for social prescribing practitioners, which sets out the skills and behaviours and competencies they need to do to have that what matters conversation with people, what the behaviours they need to really think about what's important to the individual and do it in a trauma-informed and sensitive way. So those are things that are available now. Within the framework then we've got a commitment to deliver a number of different other pieces of work to support the development of social prescribing. One of the things we're currently working on is developing guidance for community assets about what are the things we need to ensure that when people get referred into community assets, they're confident that they're delivering that service that is of a high quality. And the other thing is around how do we monitor it, and we're looking at developing core data. So those are the two things that we're really working on at the moment. And when we come to implementing it, the thing I would say has been so important is that we've had to put co-production with our stakeholders at the real centre. So we within Welsh Government could not do this on our own. We are heavily reliant on our partners to work with us to deliver all of the guidance and tools. And not just our partners, but people out there. And so we need to be testing this with people to make sure that it makes sense. We've also, within Wales, we have regional partnership boards where our sort of delivery boards for lots of health and care, integrated care projects. We've set out a ministerial expectation that they have to nominate a social prescribing champion. So we're currently working with each of those champions to develop community of practice, to understand how they reach working and operating so that we can share best practice and learning. And then finally, we'll be looking to commission an independent evaluation of the framework. So these are my personal reflections on the work that we've done to date. My main thing is the language. It's about the language that you use is really, really important, especially when you're trying to foster an understanding of complex concepts. Because when you're talking at cross purposes, it can be really difficult for people to know what it is you're referring to. So doing that work at the beginning to really be clear on what you mean by something, and then telling people what you mean, and then getting them to sort of buy into that is really, really important. And we had to do it in both languages, not just English, and they had this unique challenge as well. So it wasn't just a case of as I said, translating it from Cymraeg into English, it has to be, you have to think through the nuances of the different languages. And I think, you know, if you're thinking about doing that, then that's my big take home. You can't copy and paste one sort of model from one country into another, not even within the UK. We've got a completely different setup to England and Scotland and Ireland in terms of our delivery model. We can take on the best of what they've done and learn from them, but you can't just copy and paste. Again, it's about engaging, listening, learning and co-producing, and you need to draw on the strengths of everyone to make something that people believe in. Share the workload because we're a tiny team, and produce something that can be practically applied, because I sit in Welsh Government, I'm not a practitioner, I don't put things in practice, and so I need people to tell me whether this is going to work on the ground or not, and we've got to be able to listen to that. And then finally, the evidence base around social prescribing is growing, but it's still not, everybody isn't bought into it, and we have to continually look at the learning, the evidence, and keep evaluating and adjusting our ways of working accordingly. So that's a really quick run through. Hopefully I've got time. That's if you want any more information, and then hopefully,
there's time.
Yeah.
You can show it, yes.
Then this is our video to hopefully explain what we mean by social prescribing.
There are things we can all do to boost our health and well-being, such as moving more and being physically active, finding ways to be creative, engaging with nature, culture and heritage, learning something new, connecting with people with similar interests or experiences, helping others and volunteering, finding time to relax and play. There will be times when we might need extra support with issues affecting our well-being. For example, financial or housing concerns, long-term health conditions, caring responsibilities, or bereavement. When looking for ways to improve well-being, many people will look for help, either online or within the local community, and turn to their families and friends for advice. But this can prove difficult for some people, and this is where social prescribing can help. Social prescribing is a term used to describe connecting people, whatever their age or background, to the community to help them manage their health and well-being. People working in social prescribing will help you develop an action plan for connecting with relevant local well-being activities and groups. Lots of different organisations offer social prescribing, and there are lots of different ways to access it. People may contact an organisation offering social prescribing when they realise they need help, or when an employer, friend or family member encourages them to seek support, or be referred to an organisation offering social prescribing by professionals like a GP, nurse, support or charity worker, social worker, teacher, or in some instances, the police or fire service. Sometimes, a social prescribing organisation will contact people directly to offer support. People are at the heart of social prescribing in Wales. It is important those working in social prescribing understand people's lives and what matters to them, so they can work together to improve their health and well-being.
Thank you.
Thank you. Okay, Nicola, thank you so much. Then we are last but not least. Bring your laptop. Oh, you do?
Yes.
Sorry. Okay. Karen, the floor is yours. You're talking about a community wellness program, is it?
I am,
Yeah,
yes.
model. Yes.
So it's great to be here. I'm conscious it's the end of a really long day and your brains are probably frazzled, so I'll try and keep it quite light and just whiz through these slides. So many of you here may know that about health inequalities. In the UK, if you live in one of the most deprived areas in the UK, it's quite possible that you will die 10 years earlier than the people living in the most affluent areas, a whole decade earlier, which is just completely unfathomable, really. And actually, during your life, you probably will have up to 20 years more ill health during that shortened life if you live in an area of deprivation. So I witnessed this firsthand, the impact of social injustice, of health inequalities as my role as a GP. I've been working as a GP for 31 years, and I went into medicine probably quite naively because I had this idea that I was going to help people, that I was going to make a difference. And actually what I found for the first 20 years of my career, I was very much bound by a medical model where I didn't feel that I was really making that difference. I didn't feel like I was really helping people. And I was witnessing the inverse care law most days, the people with most need not being able to access what they needed. And actually, even if they could get in to see me, I didn't actually always have the time to work with people. I didn't necessarily have the skills or the knowledge, or I found that people were bouncing back around the system, a revolving door of referring people in, trying to tick the eligibility criteria to get them into a service or a support, and then not long after they'd come back because they'd relapsed or felt worse. And so in 2016, I had a bit of a career dip where I really questioned medicine, didn't quite know what to do next. And that started this really fascinating journey of working in health inequalities and doing inclusion health. So I've spent the last 8 to 9 years doing various roles, but predominantly it's been working with the most marginalised, the most vulnerable members of our society. And actually what I wanted to do is understand what I needed to do as a medic. How could I work with people, and actually who would know better but the actual people themselves. So I spent hours and hours out in communities, sitting with people who were experiencing homelessness, those people struggling with addiction, complex mental health, people coming out of prison, perpetrators of crime, victims of crime, just wanting to know, tell me how do I help you? What do you need from me? So this started a really fascinating piece of work where we co-created a homeless drop-in service some years ago, which was completely created by the people I was working with. They would advise me what they needed, and I'd try and coordinate. So ultimately, that project ended up with 37 agencies, once a week in the Salvation Army, in the community, and we had an open access where people would come and get what they needed. And that was where I really got my wealth of sort of knowledge. My base of knowledge came from working with people and listening to people and being guided by them. And actually all of my professional development has actually come from the people I work with and the people I try and support. So that's led me down a route of training as a coach. And what I love about coaching is that unlike the medical model, which sees people as broken and in fixing, they need fixing by an expert or medical intervention. What coaching sees people, every person, as actually having all the resources they need, and recognising that people have their own solutions, that if we take the time to create environments where people feel safe, where they can talk to us, they'll tell us what they need, and actually they will actually be able to create their own plans and their own sort of journeys for their own health and well-being. So for the last 3 years, I've been working as a therapeutic coach. So I'm trauma trained. I've been really fortunate to study with Gabor Mate and Bessel van der Kolk, who are two of the leaders in the trauma world. And I've learned so much. I mean, what I now know is that it's estimated that as much as 90% of all our illness, including mental ill health, including addictions, including chronic pain, medically unexplained symptoms, are all due to exposure to stress, particularly in our early years. So actually, the medical model is very much we're sticking plasters on when people present with symptoms, rather than really sort of digging to understand what the root cause of their distress and their illness is. And so very much we're bringing now therapeutic modalities into sort of a coaching model out in the community. So 3 years ago, I set up something called the Community Wellness Company, a community interest company, and this is a vehicle to enable us to have the agency to work in this way, because I've very much tried to sort of develop this work within the NHS, but I think it was too radical, too forward-thinking, and so I've had to sort of step out of the NHS to take it forward. So this is us. So the Community Wellness Company, we were founded Our focus was very much started about working with those with most need, people that were underserved, overlooked, the hard to reach, as we like to call them. People aren't hard to reach. We just don't want to listen to what they've got to say. Actually, if we go out and listen to people, they want to be heard. Often they've never had a voice. So they actually value people listening to them and actually taking notice of what they've got to say. So this is just an overview really of what we do. And I suppose some of the benefits of being able to work in this way is that very much our work is founded in evidence and science. We a lot of neuroscience, science around trauma, science around safety. We use the strengths-based approach. So what is quite fantastic is when you work with somebody, so I'm thinking of somebody at the moment I spoke to the other day who has been a drug dealer for most of his life, and we talked about his strengths, and he said, Karen, I have no strengths. I said, you do have strengths. You've been drug dealing. You're obviously a negotiator. You're a businessman. You've got people skills, you know. And nobody had ever in his life told him that he was good at anything. And actually, when we talked about what he might do in the future with those skills, if he could put them to good, he wants to mentor children. He wants to stop other children going down the road he went down. But he also now recognises that his childhood trauma and the abuse he suffered as a child is what led him down this route. So, you know, there's no judgment from us. There's very much acceptance, and we understand, not condone his behaviour, but we recognise why he lives as he does. And the most important part of our work is very much co-designed and delivered with the communities we work with, and it responds directly to the needs. We don't have any assumptions. While there are some common themes that we think about, poverty and adversity and mental health and trauma, the programmes become very much place-based, that we can deliver the same programme in different locations with different groups, and the details of the programme always looks different. And none of this would be possible without partnerships and collaboration. I mean, the work out there to do is vast. There's so much to do, and we recognise that not one organisation can even get close to fixing this. So we very much work in collaboration, not just with the communities, but also with partners across third sector. We work with nature partners and creative partners and trauma counsellors. We also work across with public sector partnerships, so with harm reduction, probation, housing. There's so many, I can't even think of any more off the top of my head. So this is almost our guide that we use with people that, you know, I believe that health and well-being is much more about being able to access healthcare. It's about the wider determinants of health. So we use the 8 dimensions of wellness as a guide, and this is very much what we use with individuals for them to sort of self-assess where they're currently at, what their priorities are, and actually how they want to move forward. So on the left is our model. So it's basically a series of programs that we've developed and piloted over the last 3 years with the communities. And so you can see there's the green at the top. We go and locate ourselves in a community of need, in a community of deprivation, or we go into an area, a homeless hostel, or into a particular group to work with them. And initially we do a discovery program where we start building up trust. I think it's an area that we don't often value. Certainly in my experience in public sector is we don't recognise the value of building up trust and engagement. And so it can take several months to actually just be with people and build up that trust and that sense of safety, where we can then start to rediscover what's going on for them and what they need and want. And our community connection programme is very much in community spaces, in churches, in community halls, where we have drop-in sessions, which is completely inclusive and accessible. Anybody's allowed in. And so we have beautiful communities where we have older, lonely people, with homeless people, with families, with all sorts of people, and everybody comes together and interacts, and friendships and connections are built, which is absolutely magical to witness. On the right side, this is our core team, and I have to say, in all of my career, I've never worked in such an incredible team. What's really fascinating with this team is that half the team have actually come through our programmes. 5 people here have experienced homelessness. 3 people here have considered ending their life. 4 people have had substance misuse. But actually, what brings us closer together is not our differences, but actually all that we share. So actually we have all experienced loneliness. We've all experienced complete overwhelm and anxiety. We probably all have neurodiverse traits, we recognise. But actually we're all very heart-led people, and we're all very passionate about doing the work we do with communities. So how do we know that what we do works? Well, the people we work with tell us, and for me that is enough. You know, just seeing the transformations that we witness every week, the magical transformations, is just incredible. Rivertown is one of the projects we run, and we ask people to give a word for what it means to them. And you can see there some of the words. Sense of belonging is huge. Connection, comfort, help, stability, safety, all these sorts of words. This is so important for people. I put this here. We do quite a lot of art therapies, and one of the patients I'm working with created this piece of art, and it just reminded me that he talked about how society sees him as damaged and broken and a bad person. And you know, some of the work we've been doing with him, the therapeutic work, has been around the fact that, again, his behaviour and his mental health challenges at the moment are down to his childhood experiences, which actually doesn't define him as a bad person, but that's how society perceives him. And actually, he knows he's okay, and he's on his recovery journey, doing really well at the moment. I'd like to introduce you to John. So John was actually in the group picture just before, and John is talking of social prescribing. He's one of our community navigators. So this was John 2 years ago, and he was in a homeless hostel, and at this point he had reached a real dip in his life and didn't want to live. He'd lost everything due to alcohol dependence, his marriage, his home, his job, his driving license, and he felt he had nothing to live for. Wasn't allowed to see his children. And you can see we're very careful about what evaluation measures we use and how we collect data, because we're mindful that it can be really aggressive to get people to do questionnaires and be, asking lots of questions. So we create lots of creative ways of collecting the information we want. So you can see there the 8 dimensions of wellness. People will fill that in based on how satisfied they are with life, and you can see John's was pretty bad. One is it's black, and he was very unsatisfied with every aspect of his life. And on the left, we do quite a lot of visual mapping, sort of goal setting that we use for the coaching, of looking at where people are currently living and where they want to be on the other side of the river. So 12 months after this photograph, this was John. So this is John after he's just done a talk at the Senedd, Welsh Government, in front of several hundred people, and had a standing ovation. John, at this point, last week, John hadn't drank for 2 years. He's stopped taking all of his mental health medication. He was on 6 medications. He can now look somebody in the eye and be proud of who he is. He's now got accommodation. He works with us in the team. He sees his children. He's just got his driver license back. And you can see his 8 dimensions of wellness now, what a difference in 12 months. And John will stand up and say that community wellness saved his life. He'd been through the NHS to alcohol services. He said he felt like a guinea pig, that he was clinically prodded and poked, and it didn't work for him. He tried medication, nothing was working. And working in this way is what turned things around for John. So finally, we've recently won a Health Innovation Award for this work, and so we're hoping that we'll now start getting more traction, that we can do more of this and share our learning so that more people can adopt this way of working and help as many people as possible. So thank you so much for listening.
Thank you so much, Karen. So we're now at the plenary part where we can ask some questions. And there are microphones at the side. Are there people who want to ask a question? Yes, Ree, would you please go to the microphone? Because there are people at home or people online, and they can't hear you if you don't speak into the microphone.
Hello, thank you.
Harry, would you please tell to who you are going to
I'm from Belgium. I'm actually advisor to the Minister of Public Health. I've been a GP before and worked for a long time on in the Health Insurance Administration as CEO. I have two different questions. One on the mental health support. My question would be that because we do have discussions, it is seen as something which is within the clinical process. It's a provider offers to patient. But we have a lot of discussion on having tools, digital tools, which can be some kind of substitute, which work on resilience, which work on self-management, which have the opportunity of better managing the demand for face-to-face, long, serious treatments. So I don't know if your research is on that point, looking at that aspect. Maybe it's a bit also a question about efficiency, but I would rather see it as self-support, supporting tools. And my second question is on the social prescribing. If I understand, well, I know that there are in Belgium calls. There's some calling of also committing for social prescribing, something like giving a place within the health insurance system. But if I understand well, it's about connecting. You used the word connecting between the professional system and the assets in the community. But when you do this in an active way, so in some sense you send people, you refer people to community activities. Now, people probably with problems, with some kind of some demands. How do you manage the politically, in policy making? I can imagine that from the side of communities, there is also a request of being supportive to that. Yeah, of being able to organize. So is that part of the policy also, or is it just giving guidance to the professional sector to how to think and incorporate the social prescribing in their practices? Sorry for having taken two for one. Yeah, thank you.
Yes. Yes, so if I understand correctly, your question is about whether we consider using this as kind of a standalone tool that clients would use themselves, not only with their clinicians. And this is also something that we have discussed and also looked into as a part of our work. And of course, these tools can be used by clients themselves. It's completely possible for them to monitor their mental health and look at this data themselves. But what we actually discovered in our studies and when we talk to people is that clients really want someone to help them with this process, that many actually felt like they weren't really competent to do it themselves. And I'm not saying they're not, but that was their feeling. And what we saw was that the effects that people got from using the tool, so these effects where they really got insight and could see, like, this is what I want to work on, and this is what I want to do, and this is how I can improve my mental health, that very often this co-interpretation and this dialogue that they would have with their clinician would really be like a key to unlock that. And I'm not saying clients can't do it themselves. I think they can. I think they can, open that lock themselves. But having that interaction, dialogue, and feedback with their clinicians really, open that lock a lot quicker. They really wanted someone who could help them reflect on their data, to make sense of it. And also to then see, like, okay, but what do I then do with this? I can see that these situations are situations that are difficult for me. I can see my mood goes up and down and varies in different ways, but what do I then do with this data? And then having someone who can also help you translate that into concrete goals and also help you follow up on that was perceived as really valuable. So it can be used by clients themselves as a standalone tool, but it really, what we see is that really having the support of a clinician, you just have much more effect, at least in our studies.
Okay. Is that an answer? Okay.
And I think in terms of the question that you posed me around the role of community assets within social prescribing and whether the framework is working to address some of the concerns that some people might have around referring people into community assets. I know when we had a lot of the engagement work, when we heard to referrers from like GPs and others, they were really concerned about where the sort of the risk lay and where the responsibility lay. That came through really strongly. What also came through really strongly was that without community assets, there is no social prescribing. So without like a really good base of community assets that people can be referred into and can be supported in, then there won't be social prescribing because there will be nothing for people to sort of take up. So the framework, one of the commitments in the framework is around developing standards for community assets. We've just started on that work now. We've started to sort of get into the detail of it, and what's been really interesting is getting that balance between having safeguards and procedures and processes in place and not overburdening local community groups, because you know, if someone set up a local knit and natter group, the last thing they want is to be filling in hundreds of forms and doing loads of risk assessments. So the feedback that we've had, and we're in the beginning of that work, is that it would be helpful to take a bit more of a tiered approach to it, based on risk. So it could be a very small group that was interested in cold water dipping, which would need to take a much more of a risk-based approach than a knit and natter group, for example. So it would depend on the activity. So that's the thing that's starting coming out of our initial engagement. The other thing that's starting to come out of the initial engagement is that it needs to be a two-way thing. So it can't just be a case of somebody from a social prescribing organisation referring them into a community without giving any thought about whether that works for that individual and just leaving them to it. There has to be that two-way communication between social prescribers and local community assets, so that they can, so that we don't have that inappropriate referrals. Because once that starts to happen, once you start taking advantage of these local groups, then the goodwill goes and the trust goes. So our role in government is to develop the sort of national standards, but then how that is then implemented is for local partnerships to look at. But one of the things we're thinking of maybe doing is developing maybe a code of practice that people sign up to. So those are the type of things that we're looking at the moment. But yes, it certainly is part of the referral, the piece of work that we're looking to do.
Wonderful. Is that an answer to Rie, to your second question?
It's opening another question.
You have to go to the microphone because they have to hear it online. Thank you so much. It's good for your exercise.
It opens. Yeah, thank you. You are socially prescribing for me. Thank you. It's appreciated. No, but does that mean, in some sense, that you, at the side of the professional sector, you have some professional social prescribing profile, which is
yeah. So we see the social prescriber as a social prescribing practitioner as a skilled role. So we see that as definitely something that needs to have that level of skills. And so that's the competency framework that I talked about that's been developed. The next phase of that work is translating that into a series of training courses and maybe qualifications as a consequence of that then. But no, we definitely see those social prescribing practitioners as being a very skilled role. But, so to be able to have that what matters conversation with somebody, it's not just a case of, oh yeah, there's a book club there. It's about talking to them to understand what is important to them. And part of what the framework will do is to build the capabilities across Wales, so that everybody has got that skills development.
Okay, thank you so much.
Thank you.
Thank you so much. Please introduce yourself.
Okay, sure. I'm Marianne Saragosa, and I'm a neuroscientist in Toronto in an acute care hospital called Sinai Health. I've also been part of an evaluation team that has been evaluating the Canadian Institute for Social Prescribing. And one of the big, points of discussion is around the data. So as we want to build a national framework and capacity across the country for social prescribing, we need the Canadian data to demonstrate its effectiveness at the local level. And because we are a country of provinces, and each province has its own system in terms of data, indicators and so forth, it's always been top of people's minds on how to, not only how to collect the data, but what to collect and having common indicators across the country, which is very challenging given our multiple healthcare systems. So that's one question, is how will you, collect data, or do you have a plan to collect data? And how do you identify what those common outcome measures or indicators might be? And then how do you share data? Because, as we are prescribing to different sectors, social care, that's data transfer doesn't often happen. There's a lot of privacy concerns around that, and that's something that we also are grappling with in Canada. So just a lot of questions, but it's really just around the data piece and evidence.
So in terms of the data, we're in a very similar situation to you in that it isn't routinely collected in Wales at the moment. So the data that we've had, and we commissioned the School for Social Prescribing Research to do a baseline back in 2019, which informed the work, and we're currently sort of following that up with another exercise through the regional partnership boards to sort of get a more up-to-date picture about what's happening, but we don't collect it routinely. So part of the commitments in the framework is to start that process of collecting it routinely, and I think it's something that will, which will evolve and develop over time. So I think even if we are routinely collecting demographic data in the first instance, that will begin to tell us something that we don't already know at the moment in terms of who is using the services, where they've been referred into, what the sort of demographic makeup may be of them, so we can begin to understand if there are some cohorts that are accessing it more than others. So that's one of the first things that we're looking to develop. But then I think we then need to move on to measuring outcomes. And then, of course, it's really difficult in this space, because do you measure the outcome of the individual project, or do you measure the outcome of the sort of what matters conversation? And so we're still working our way through that. I think we probably need to separate those two things out. So separate out the project level outcomes from the sort of main sort of program, what different social prescribing per se is. So we're really fortunate in that we've got really excellent. The Wales School for Social Prescribing Research is really at the forefront of a lot of this work in terms of helping us think through some of that. We've been working really closely with colleagues in Public Health Wales and others to think through how that might work in practice. So we don't have the answers yet. It's on our worry list, but it is definitely, but we've made a commitment to do it. So, and we'd be really happy to share what we are doing, and similarly, we'd be really happy to learn. We're very good at learning from others as well, if we can. So it's not copying, it's learning. Yeah. So So really, really interesting question as well.
Thank you so much.
Okay, thank you so much. Are there any questions? Yeah? Please introduce yourself.
Hi, thank you all for your very interesting presentations. I'm Marie-Laure. I'm also a researcher at KU Leuven, just like Lena, but we have never met. But I have a question for Isabel, because you're doing a survey. This mic is so high. You're doing a survey for these young carers, and I was wondering, are you questioning people that are under 25 right now and that are caregivers right now, or are you also questioning people that once were caregivers when they were young and they are now grown up and they can like reflect on their situation. So yeah, that's kind of my question. What's your aim for that?
Wonderful. Yeah, thank you for your question. To clarify, so our survey is for healthcare providers. So right now we're not surveying any young caregivers, but they are involved in the co-design workshop. And so our age range right now is 16 to 25. There are young caregivers kind of below and above that range, but institutional kind of limitations, we couldn't go lower than 16. And we definitely have young care advisors on our team who are above that age of 25. I definitely agree that there's a lot of lifelong reflection of being a young caregiver as you kind of transition from being a young caregiver to being a not young caregiver, or if you're a young caregiver and no longer have that caring role. So I think inclusive of both those types of caregivers, the current ones and the ones that are able to speak to their experience are represented through our co-design workshops and our advisory group.
And are you planning on also doing a survey to question them or not?
So not right now, but one of the papers that I spoke to that is kind of the background for why we did this work is that there was qualitative interviews done with different young caregivers that helped to kind of illuminate their challenges interacting with the healthcare system and the different kind of ways they supported their loved one as they interacted with healthcare. So we have the qualitative interviews as that kind of foundation for their experiences caring with the healthcare system, but don't have kind of a survey. That definitely could be something to do, but we do have that kind of foundation from the qualitative research.
Okay, thank you.
Thank you.
Okay, thank you. Are there other questions? Do you have a question?
Yes, hello, I'm Rachel Jenkins. I work in community nursing in Switzerland, and I've got another question about social prescribing, so I'm sorry we're hopping a bit. Me and my colleagues are often in the role of detecting social isolation, loneliness in our patients we care for at home. So we get into this role of mediating possible activities, contacts. We know what the offers in the community are. And I find it difficult to sort of envisage somebody, me saying, oh, I'd like Mrs. Miller to meet you. She's from social prescribing. She'll talk about the possibilities for you to get in contact with other people because, it's this question of trust, and you have to build trust, and then people slowly open up to the idea, and just mediating somebody into an intermediate role with the aim of facilitating social contacts or activities in the community. I'm just not sure how effective that can be from my experience of socially isolated and lonely people living in the community. So I'd be very interested to hear your...
Yeah, and that's a really valid point, and something that, when we looked at the definition of social prescribing, why we decided to come down to it as being as a function rather than as a role. So the function of social prescribing is a function of connecting somebody to the community. So you're doing social prescribing. If you were in Wales, you would be doing social prescribing. So it's not a role as such, it's that function. And so what the framework is trying to do is for people who are doing that function, who are doing that activity, is to put in the support to help them. So it could be that in your instance, it could be that you might draw on some of the support that's there. But for others, they may not have the time, they may not have the capacity, and so it would be appropriate for them then to refer on to somebody who could offer them that time, who could offer them that capacity. So we had lots and lots of debate about the definition of social prescribing. And as I said, in the WHO definition of social prescribing is very much about a person and about that role, whereas we've stripped it right back to that function of connecting people. So that's what you do. And social prescribing has been around for years. Occupational therapists have been doing it for years, nurses have been doing it for years. What they've started to do now is to introduce a new is a new role for people who just don't have that time to spend with individuals that they might have had in the past. So that's why we've landed on the definition that we did. And the other thing I should have said as well is that we wanted social prescribing not to be a gatekeeper to other things. So it wasn't that you had to go through somebody offering social prescribing to access all of these things. You know, if you could do it yourself, then do it yourself. You know, I often talk about my mum in this situation. My mum joins all of these groups, she's fine, but my uncle couldn't, and so he would need someone to help him. So it's about making sure that social prescribing isn't seen as a gatekeeper to doing things that can help you either. So that was a really important thing I forgot to say earlier.
Thank you. And it would be financed over the NHS in Wales? Because I don't know who would finance a role or a
You're running a little bit out of time, and you have somebody behind you who wants to ask a question too. Sorry for interrupting.
Thank you very much.
Thank you so much.
I promise my question will be quick. My name is Valentina. I work at the SE Research Center at SE Health in Canada. And my question is for Isabel. I was wondering, you mentioned that you did co-design with young carers as well as healthcare providers. I was wondering if in any of the sessions they were together, and if so, how did you kind of balance the power dynamics between those two groups?
Yeah, that's a really great question. Thank you for asking. They were, I'm just trying to think back. So for sessions 2 and 3, they were all together and in breakout rooms, and those breakout rooms were mixed. And we talked beforehand about kind of how we were going to make sure that young carers felt comfortable in a space with healthcare providers to share, and that role, or that kind of doing so kind of rested on our facilitators, so making sure people kind of, we got to know each other in a group and learned a little bit about our story, and then also the facilitators to kind of call on people, you know, if they weren't really sharing, and kind of bridge them to feel comfortable with that. I think one of the things that it just speaks to kind of who's at co-design is we've heard from a lot of healthcare providers who are really passionate about young carers, and so are really, you know, have some of them have lived experience themselves, and so I think that like shared passion and shared understanding helps to facilitate a breakout room that creates that space where people feel comfortable sharing. And then our young caregivers who are there, I think a lot of them are also really passionate and are very outspoken about it, and so we kind of also just happen to have a group where people feel comfortable talking, but it's something that we are always mindful in terms of how we facilitate and how we share airtime, and then how we kind of structure our activities, so we give people space to kind of share from their own experiences. But that's really important to point out, so thank you for asking.
Okay, thank you so much. I have a very short last question for Karen. And addressing social injustice and health inequalities is that's so important. You do that with the wellness, with this community wellness program. And you had a word cloud, and in the word cloud you had some words like coping, community, health, belonging, etc. How does this interact with different cultures, and how does this interact with lower and social status?
Let me think. I would say, I think this is the actual. I think it's all about connection. For me, I think wherever you live, whatever the culture. Interestingly, there was a mental well-being survey that was released last month, which looked at all the countries across the world and scored mental well-being. And the countries that scored really high were Asia and Africa. UK was second to bottom. And a lot of the Western countries were low down on the scoring. And I think when you look at some of the factors, I think it's our disconnection actually in the Western world that we've become very disconnected. We're very, we don't live in communities quite so much as we used to. We're very reliant on tech, and I think there's a real place for tech, but I think it's resulted in people becoming quite disconnected. Whereas I think in the countries that scored higher, it was very much they live in communities or tribes where people are really connected. Yeah. People aren't excluded if they commit crimes. They don't get punished and marginalised. They actually get brought further into the tribe and given more love. So I think, and that's what we find. I think, my belief now is that we've really overcomplicated healthcare, and I think actually when we go back to basics, I think 70% of the healing that's done with the people we work with is those basic human needs, which is connection, sense of belonging, sense of purpose, and actually I think
that sort of
Yeah, they're very, very much lower in the pyramid of Maslow. Yeah.
Exactly,
Yeah,
and so that applies whichever country you live in and whichever culture
doesn't matter.
you're in.
Okay.
Yeah.
Thank you so much. I want to thank the presenter. Thank you so much, and thank the audience. Thank you so much, and have a good conference.